So weight loss कर calories in calories out.
Hey guys, good evening. Hope I'm audible and visible. If someone of you is online, just can you say hi and hello? Just to confirm you can see me and you can hear me. So one more day, one more session of Robbins. Hello, good evening, Lion. As usual on time. Okay. So we are going to continue the intracellular accumulation. Hello Lilith. Hello Osama. How are you doing, Osama? Hello Rehmani. So we're going to complete the intracellular accumulation part where we'll be discussing about the intracellular accumulation, the last part of it, sorry for it, the calcification. Fine. So we're going to discuss about calcification. So good evening everyone. So the calcification, if you have gone through Robbins, I am sure you must have read about that. We also discussed calcification in the live batch couple of days back, right? Okay, great. Hello Lalit. So we will definitely go ahead with calcification. Here calcification is one of the most thing which is close to my heart, because if you read calcification the way I'm going to tell you, that will definitely make you a little bit more interested towards Robbins and the standard textbooks and medicine. If you hate medicine, if you feel that, oh, I made a wrong decision, calcification is something which can change the entire thing together, because the beauty of calcification is there only in the terms. How many of you have read calcification from Robbins? Have you gone through? So if you have gone through the Robbins calcification, there are two types of calcification. One is dystrophic calcification, the other one is metastatic calcification, right? Like I said, everything is there in the terminology. Dys means abnormal, right? So dystrophic, trophy is normal, right? So trophy is your tissue, hypertrophy, bigger tissue, right? So trophy means tissue. Dystrophy means it's going to be an abnormal tissue, that's all. It's just nothing, means literal translation is an abnormal tissue, fine? Meta, how many of you know what is meta? We read about metaplasia as well, right? Okay. Lalit, Cushing syndrome, there's excess glucocorticoids, buffalo hump, round face, stray, you'll have hyperglycemia. These are the few features that comes on the top of my mind, right? Meta means change, right? Metastatic, right? Stasis means here homeostasis. So metastatic calcification, the literal terminology meaning is it's change in the calcium homeostasis, which is causing deposition of calcium. That's all metastatic calcification means. That's all, right? Now, with this basic understanding of metastatic calcification, let's go to that's metaplasia, Osama, right? You're right. Let's go to the Robbins book, because if we think that if I'm going to write something and it's easy to understandable, but if book is difficult, then it's difficult for us to read the book, right? Let's go with the book and see if it's comfortable for us to read the book. So just keep in mind, metastatic calcification means it's change in the calcium homeostasis. I want everyone to answer here. When do you think the change in the calcium homeostasis is going to cause deposition of calcium? Right? Amazing random facts. I don't teach in the bed, right? Sorry for it. Okay. So which change do you think it will cause deposition? Hypocalcemia or hypercalcemia? Hypo or hypercalcemia? Obviously it's going to be hypercalcemia. That's what the first line in Robbins says, right? If you look at it, whenever there is hypercalcemia in a normal tissue, the calcium gets deposited. That's a simple fact which everyone knows, right? So it's hypercalcemia. So when I'm going to have hypercalcemia, again the book is there. Don't look at the book, just answer to my questions. Which hormone controls calcium metabolism? I'm sure everyone knows that. Parathormone is one which controls the calcium metabolism, right? So when there is more parathormone, there's more calcium deposition, right? So we'll have hyperparathyroidism. Whenever there's hyperparathyroidism, it will cause calcium deposition, right? Sure, Rahul. Good evening. So I'm going to have increased secretion of parathormone, which is PTH, which results in hyperparathyroidism. Because of the hyperparathyroidism, you're going to have hypercalcemia. The reason for hyperparathyroidism is what given next. Parathyroid tumors. Obviously, right, parathyroid adenoma will definitely secrete more parathormone, which results in that. Or ectopic secretion of parathormone related to malignant tumors. We'll see the malignant tumors related parathormone excess secretion when we come to neoplasia. But for me, now, excess parathyroid secretion or hyperparathyroidism can cause hypercalcemia, can cause metastatic calcification. Again, don't look at the book. Just tell me which are hormones, sorry, which organ in your body do you think has maximum calcium? Which organ in your body has maximum calcium? Bone, right? So if bone has maximum calcium, can I say that if bone is being resorbed at a fast rate, right? Resorption of bony tissue. If my bone is being removed at a fast rate, automatically it can cause deposition or hypercalcemia. It can, right? So that's the second point here. When I resorb the bone faster, not slow, faster. Because when I resorb the bone slowly, homeostasis and regulation will happen easily. When I do it fast, obviously it will result in hypercalcemia. When you look at the things given here, it's resorption of the bone secondary to bony disorders like multiple myeloma. In multiple myeloma, when we go to hematology, we'll read that it caused punched out light lesion, right? Multiple myeloma have leukemias or diffuse skeletal metastasis, breast cancer, accelerated bone turnover, Page's disease, right? If you want, you can remember these, that's fine, or at least remember any disease which results in fast resorption of bone. The reason I am not more emphasizing on the examples is, if you finish pathology, you will know more examples than these. Ultimately, it's about managing the patient, right? When you finish pathology itself, you'll know causes of bone resorption, so you not memorize that, but just remember increased bone resorption, that's all, fine? If vitamin D is deficient, what disease does it cause? From your biochemistry, vitamin D deficiency. It causes rickets, osteomalacia, right? It definitely causes rickets and osteomalacia. So if vitamin D is intoxicated, because when vitamin D is gone, calcium is less. That's why my bone is not growing properly, not maturing properly, right? So when you have a vitamin D intoxication, right? That's the thing. Intoxication of vitamin D, which can happen, excess vitamin D related, which can happen in sarcoidosis, where also I'm going to have more vitamin D, that's all. So if it's excess calcium, hypercalcemia possibility, right? That's a third point here. I'm just going with the etiology with the term metastasis with whatever is given in the Robbins, as simple as that, right? Last one which will be given in Robbins, which is important for me, is kidney. Can I say kidney is an organ which will secrete or excrete almost all ions in the body? It does, right? So kidney also secretes or excretes your phosphate. So if you look at kidney, whenever there is a renal failure, there is retention of phosphate. The phosphate is going to get retained. Samantha, sarcoidosis is a disease. We'll read them when we come to the latter half of pathology. It will be much comfortable. As of now, remember, it's an autoimmune inflammatory disorder, right? So renal kidney is going to fail, phosphate will be retained. Because of retained phosphate, my calcium homeostasis is going to be affected and parathormone will be secreted, right? That is one of the cause of secondary hyperparathyroidism. So there's a renal failure, ultimately increases more parathormone. If there's more parathormone, calcium levels is going to be more, hypercalcemia, the same routine here, right? These ones are not much important for me. When Robbins in the general pathology say less common, not really important. Almost 99% case of hypercalcemia, what you see will be in this 4 only. Rest is 1%, maybe milk alkali syndrome, aluminum intoxication. Hardly happens. If you want to fill up the pages, great. Otherwise, need not remember that. Our goal is to treat majority of the population. If you can know 95% about any disease, that is enough. That will be there in close to 100% of your patients in real life, right? So if we know basic 4 things, which means it's hypercalcemia, that's a main pathogenesis. And we understood it by saying it's a metastatic change in homeostasis, that's all, fine. So the change in homeostasis name, we know the etiology. Samantha, secondary hyperthyroidism means it's not a primary parathyroid disorder. Primary parathyroid disorder, it's a kidneys disorder. Because of the renal failure, parathormone is having excess secretion. That's what I call it secondary cause. Not a primary cause, a secondary cause. I hope it's clear, fine. Now, we all know from this term, there's going to be hypercalcemia. Okay, now let's go to the presentation. When I'm going to have more and more calcium in the blood, can it get deposited in the tissues? It obviously can. It's not a rocket science, right? I'm going to give you 2 options here. Calcium is a mineral. I'm having a big aorta where the flow of blood is going to be gushing very fast. And I'm having a very tiny vessel where the flow is sluggish. Where do you think there's more chance of deposition? Aorta or a slow flow or a sluggish flow? Any day it's a sluggish flow, right? So only in a sluggish flow, there's a possibility for me it can get deposited. Sluggish flow means capillaries. If you remember capillaries, right? So there are multiple things in capillaries, multiple organs in my body which can have capillaries. One of the important organs is your creatinine is a test to test renal disorders, fine. Your lungs, your kidneys, right? So if we take here, this is where I am going to see the metastatic calcification. Kidneys, lungs, Systemic arteries little bit, veins a little bit, but these are more important for me because these are the organs where the amount of capillaries is very high, so deposits can cause calcification, right? Next, gastric mucosa. The reason for gastric mucosa here is very simple. If you remember the physiology GIT, you must have heard that pancreatic secretion has the maximum pH, lots and lots of bicarbonate. So let's assume, I'll come to Samantha. I'll come to Nike, just give me a second. Let's assume that when calcium goes to GIT, the bicarbonate levels in the GIT converts them into calcium carbonate, calcium bicarbonate. A salt, can it get deposited? It can definitely get deposited, right? So that's why in gastric mucosa also, I have lots of deposition of calcium, right? So here, the same thing. Whenever there's an alkali compartment more, the calcium salts will get deposited. That's what happens in your metastatic calcification, all the places, right? Now let's go to whatever notes we have created out of it. I'll answer both your questions, Samantha and Nayak. See, if the blood flow is slow and sluggish, it need not be always right that auto-regulation will happen. If there's a sluggish flow, it's not being washed away properly. So auto-regulation also is a bit difficult to happen, right? Okay, Nayak, wherever there is capillaries, there's definitely chance of calcification, which means every organ in my body has a chance of calcification. Will meninges undergo calcification? It depends on the duration of the hypercalcemia and how severe it is. It's the probability. Kidney and lungs have very high density of capillaries, so they get affected first. Heart also will have. Every organ in the body will have. But based on the probability, this happens more. That's all, right? Okay. Now, if you look at the metastatic calcification, that's what I've written. It's change in calcium homeostasis. That's all. Which means the pathological event here is hypercalcemia. That's what there in the first line of Robbins. So if you remember hypercalcemia, we know that hyperparathyroidism, any bone resorption if it's fast, vitamin D intoxication, and secondary cause of renal failure, post-renal failure, obviously you'll have an increase in parathormone. All these are etiologies for your metastatic calcification, fine? Samantha, primary parathyroidism means there's a problem in the parathormone, like parathyroid adenoma or parathyroid hyperplasia. Rahul, I'll definitely reply, Rahul. It's busy today, I'll definitely reply, fine? So the presentation is, due to the increased calcium deposition in the blood, lungs, it's the most common organ, and kidney, it will deposit, which causes renal calculi. You must have definitely heard about kidney stones. The reason is, they're all capillary rich structures, fine? GIT, there's a salt formation. Because of salt formation, how the patient's presence is, the patient present with abdomen pain. This is the presentation, this is the reason, right? I have salt formation, there's an abdomen pain. Okay, Lalit, CR views, it's a venous hemorrhage in the eye. Ophthalmologist will be a better person to answer than me. Fine. Okay, I hope you're asking the ophthalmological condition. Psychiatric problem also will be there. In psychiatric problem, because calcium is a very important neurotransmitter. Because of hypercalcemia, the patient's neurotransmitter things will have a problem. The patient will feel irritated, anxious, and lots of changes will be there. So these are all the symptoms of metastatic calcification. Okay, again, everything we extrapolated from the term metastasis, which means change in homeostasis, right? It's very simple. Try to connect. If you connect each and everything, it's much easier for you to remember on a long run. Now let's go to the second term, dystrophic. So like I said, this means abnormal. Okay, this means it's an abnormal tissue, that's all. Trophy is tissue, this means abnormal. When I take an abnormal tissue, I'm going to divide the abnormality into two major groups. The first abnormality is, I'm going to call them a degenerating or a dead tissue, or an older tissue and a dead tissue. Both are abnormal for me, right? It's not that only dead is abnormal. A old age tissue is also definitely abnormal for me. It's very old, right? Let's take an example. It's an old tissue. Let's assume heart. Before going to the heart or old tissue, I'm going to ask you a simple question, which I am sure most of you will know. What do you think is the most common ion in case of necrosis? What do you think is the most common ion in case of necrosis? The most common ion in case of necrosis? It's calcium, right? So which means whenever I'm going to have a cell death, I'm going to have more calcium. That's by default. So which means if a cell dies due to trauma, calcium will be more. If a cell dies due to any other process, calcium is going to be more, right? So when I take degenerating on an older tissue, I have two examples written here, cardiac valve and blood vessel. If you look at these two, there's one common denominator here. Both are in the vascular thing, right? Lalit, I'm not the right person to answer that. Till 10 mm, yes, it can be. It comes under the surgery person. Please ask Dr. Sandeep. It's a very complicated thing. I don't know the latest protocol, so I don't want to comment on that. Fine. If you look at the things, heart is the biggest vessel. It beats every second. The vessel, the blood vessel, it also has the same pulsations. Every minute, 60 to 70 times, it's going to move like this. In other words, these two organs, there's a very high chance every day there can be trauma. Though my blood is being pumped at a very fast rate, the valves open, but can I say the force of the blood can hit the valve and definitely cause tiny trauma? It can. That's what happens in old age. When this happens for 20, 40, 50, 60 years, there's definitely a possibility in both heart as well as the blood vessel, there can be micro trauma and micro loss of cells. When those cells die, you'll have more calcium. That's what happens here. And this calcium is local calcium. When I say local, it's there in that tissue, not throughout the body. So the serum calcium here will be normal, but the local calcium increases. That's dystrophic one half. The second half of dystrophic calcification is Psammoma body. It's a very important Viva question. Definitely it might come in exams. Right? Psammoma body is nothing but, Psammoma means sand. The calcification here looks like a sand, gritty like a sand, right? So if you read Robbins, it will be written, maybe I have Robbins here, let's go through it. If you go to the dystrophic calcification Robbins, the one common thing where what will be written in Psammoma bodies is almost always one thing will be there, which is papillary carcinoma thyroid. Where did it go? Papillary cancers. If you look, actually it's written some types of papillary cancers. Actually it's every papillary cancer. Whenever I have a papillary tumor or papillary thyroid carcinoma, I'll have Psammoma bodies. We're going to take this part. Some types of papillary cancers, example thyroid. Let's see why it's going to cause this. If it's isolated, most likely it's genetic, Kamran. Look at the gene, take the family history, you will have the answer. Because 450 is very high. I need the age also for that matter, right? So Psammoma body happens in two places. Whenever a tumor has a papillary appearance, and whenever a tumor has a whorled appearance, right? Whorled appearance, I'll tell you, you can see this is the whorl. It's like a circle, right? Whorl. Whenever a tumor has a papillary appearance or a whorled appearance, you will end up in having Psammoma body. The reason is very simple. Papillae, the definition of papillae is a finger-like projection with a central fibrovascular core. This is how a papillae looks like. Okay? Papillae means the vessel should be there in the center by default. If it's not there, it's not a papillae. It's a villi. No vessel means villi. If there's a vessel, it's a papillae. If you look at this papillae, can I say this tip of the papillae will have less blood supply? Is that statement right? Yes or no? Because the vessel cannot go till the tip. It will turn and it will come down, right? The tip of the vessel will have less blood supply. Whenever there's a less blood supply, is there a possibility there can be ischemia? Yes. Can there be an infarction? Yes. Whenever there's an infarction, there's tissue death. What's the most common ion? Calcium, right? Calcium, right? Okay, Rahul, micropapillae, pseudopapillae is not the reason here, because micropapillae don't have a vessel, right? And pseudopapillae also don't have a vessel, right? So what happens here is, whenever I have a papillae here, the tip will have less blood supply. When the tip has less blood supply, I have a chance of an infarct. Whenever there's an infarct, the calcium deposits and I'll have Psammoma bodies. So now tell me, Psammoma body is seen only in papillary thyroid carcinoma or any carcinoma with papillae? Is only papillary thyroid cancer or any cancer with papillae? It's with any cancer with papillary appearance, right? If a cancer in microscopy has papillae, it can have Psammoma bodies, that's all. So how do I know which all conditions Psammoma bodies can happen is, if the tumor has papillae in the name, people are not complicated. If I see papillae in microscopy, I will call it papillary tumor, as simple as that. If I have a tumor, papillary carcinoma thyroid, papillary carcinoma of breast, papillary carcinoma of kidney, I think of Psammoma body. Or if the tumor has serous in the name. If the tumor has serous in the name, microscopy will have papillae. That's how the terminology of tumor is, right? I'll answer your question, Rahul. Kamran, most likely is genetic, then age is 22, most likely genetic. Pseudopapillae is not exactly equivalent to micropapillae. When I have, like, I'm sure you must have heard about a tumor called Warthin's tumor. This is for Rahul, since he's in the end of second year, he knows about this. So Warthin's tumor also has a papillary appearance. It looks like a normal papillae, but no blood vessel. I call it a pseudopapillae. Micropapillae is a very tiny projection. It's actually not a papillae. I have cells here. The cells project like this. It's not actually a papillae. That is called as a micropapillae. Fine. It's a projection of a cell which is called as a papillae. Fine. Okay. Let's come back to this. So if a tumor has the name papillae in it or the name serous in it, microscopy will have papillae and they will definitely have Psammoma body. That's the first extrapolation. The second is whorled appearance. When you look at this whorl, what happens is the blood vessels will always come from the outside. In any whorl structure, the blood vessel has to come from the outside. When a blood vessel comes from the outside, can I say the center of the whorl has chance of having a less blood supply because the blood vessel comes from the outside? Yes. So this center part has a very less blood supply. Less blood supply, ischemia. Ischemia may lead to infarct. Infarct can result in cell death. And what's the most common ion in cell death? Calcium. Can they cause calcification? It can obviously cause calcification, right? So center has less blood supply. Sure, Lilith. When there's less blood supply, there is infarct. When there's infarct, I'm going to have calcium and I'm going to end up in having calcification or Psammoma bodies, right? So there are two tumors where I can see calcification due to whorl, leiomyoma and meningioma. So all these can end up in having Psammoma bodies because Psammoma happens whenever there's an ischemia. Whenever there's cell death, Psammoma happens, right? That's the concept about Psammoma body. All this can definitely have Psammoma body, right? Anything, if you have a short note on Psammoma body, just write that these tumors, you can name whatever it is, all these can have Psammoma body, and your exam viva also can answer conceptually, need not memorize them. Tell them any tumor with papillary appearance, any tumor with the whorled appearance can have Psammoma body, right? So we know dystrophic also, right? So dystrophic means dead tissue or a degenerated tissue, old tissue. In both, the only thing is local calcium is going to be elevated, and obviously serum calcium level is absolutely normal because it's not change in homeostasis, right? So how to revise this is just read them, that's enough. The good thing about Robbins in medicine is when I know the etiology, I tell this is the etiology, this is the pathogenesis. If I don't know the pathogenesis, I tell that it is idiopathic. If it's idiopathic, memorize. If I know something, don't worry. You can extrapolate normally. If you extrapolate, if you connect one by one, you will never ever forget it, right? So first reading, please give time. Don't hurry up during the first time reading. If you read first time correctly and revision is more than enough. Dystrophic, dead, everything is connected. Metastatic, change in homeostasis, everything is connected. I'm fine, Priya. Rahul, I'm not able to understand a question. In PAN, it's a medium vessel vasculitis, so any vessel in the medium range will get affected. Okay. So now our concern is always to diagnose. We know dystrophic, we know metastatic. I have to diagnose. I'll show you calcium in your microscopy. This is how the calcium is. This is how calcium looks in microscopy. Pink or blue? What comes to your mind? Pink in color or blue in color? It's definitely bluish in color, right? So what else is blue color in my biopsy? There's one more thing which is blue color in the biopsy. That is nucleus, right? It's definitely basophilic, it's definitely blue. Nucleus is also blue in color. So as a pathologist, it's difficult for me to differentiate nucleus blue from calcium blue. So what do? We use stains, right? I just need your template. If you form a template, you will never miss it. Whenever I'm having difficulty in diagnosis, I use stains, special stain, right? There are two special stains for calcium. One is Von-Cosa, okay? The other one is alizarin red, okay? For calcium Co, if you can maybe try to relate it, it's fine. CaKO, right? Von-Cosa is the commonest stain used for calcium. Alizarin red, though it's a specific stain, it's a bit expensive, so we don't use them, right? This is not there in Robbins, but I would say complete with this, because whenever you're reading something or writing something, there has to be a patient application. Okay, Mallika Raghav, it appears pink to you. Maybe I would say this part here is more eosinophilic. See, this is nucleus. Do you accept this is blue? If this is blue, this is comparable, right? That's more blue in color. Okay. I hope that's answered your query. This is the world appearance. This is from a side of a meningioma. That's how your metastatic calcification looks like, or your Psammoma bodies, sorry, dystrophic calcification Psammoma bodies looks like. Fine. Okay. This might look a little bit pinkish. Again, this is an older slide, but generally calcium is blue in color in microscopy. That's all. Fine. Okay. That's a little bit topic about today's topic of calcification. With this, we have completed the intracellular accumulation. I'll have classes on Robbins-based pathology next week also. Please do comment on what you want to go with. Maybe we'll take 2-3 days to break down a difficult topic for you, whichever is big. Fine. Okay. Please, Priya, if I miss something, do let me know. I'll answer it. ELISA is a microbiology test. ELISA, how to explain? See, ELISA is, let's assume that I'm having a cell. On top of that, I'm having an antibody. So what I do is, I add a reagent which binds to this antibody. And then if the antibody is present, I have positive. If this antibody is not there, only the cell is there, the reagent will not bind to it. So it becomes negative. That's the simplest way I can explain ELISA. Rahul, I'll look into the Instagram. I'll definitely answer your queries. Yes, Layan, you have to. Bhaumic renal pathology for a second year is a bit difficult. I want this Robbins to go for the second year of MBBS. So I'll go with general pathology. I'll definitely take renal pathology a little bit later. Fine. I want to set the base right so that they can read Robbins. Fine. It's Ranjith pathology. I'll do the initial chapter. I'll create a poll. I'm not so active on Telegram, Lalit. Go with Insta. Fine. I'll start with inflammation. We'll go with inflammation. Simar, OR rods are finding seen in leukemia. The normal finding seen in leukemia. It's nothing but the same granules of the granulocyte. It's looking in the form of a rod. That's all. Neutrophil has granules. The same granules looks like a rod. I call it an OR rod. If there's a query related subject, please ping me back or ping me on Instagram. I'll be more than happy to answer your queries. I'll do it, Rahul. I'll do it for sure. Okay. If there are no more doubts, we'll call it a day. See you in the next class. Till then, bye-bye. Keep reading. Keep enjoying Robbins. Bye.